This year, we need to start ourselves. This year, we will never give up. This year, be ready for the challenges of life, and this year will be yours and mine. It is quite late, but still speaking that, Happy New Year. Hello guys, this is Vikrant Sengar, pursuing MBBS from GRMC Gwalior, now presenting a beautiful lecture on the great topic that is the Appendicitis Part 2. So let's get started. So guys, due to the health issues, I was not able to record videos for you, but now we will discuss the part 2 of acute appendicitis. And we have covered the part 1 of the acute appendicitis, and we have covered the anatomy of appendix, followed by the etiopathogenesis, clinical features, and the complications of acute appendicitis. And today we will discuss the diagnosis and the treatment and management. Okay, so the first is the Mantrels score, followed by the CECT USG findings, followed by the histopathology and the appendectomy and the OSCHNER SHERREN regime for the management of appendicular lump. And today we will cover the pathology, medicine, radiology, and surgery in the part 2. Okay, so let's get started. And the diagnosis of acute appendicitis is purely clinical, and we will rely on a scoring system, that is the Mantrels score or modified Alvarado score. Okay, so M stands for the migratory pain, A is anorexia, N stands for nausea and vomiting, and T stands for the tenderness, R is the rebound tenderness, E stands for elevated temperature, L is leukocytosis, and S stands for the shift to left. So before we discuss the Mantrels score in detail, we will discuss and we will check for the McBurney's point here. So this is the anterior abdominal wall, and this is the chest portion here. Okay, and this is the umbilicus, and this point is anterior superior iliac spine, right? And the line joining between the two is the spinoumbilical line, and here's a point. This point is called as McBurney's point, which is present at the junction of medial 2/3, this is medial 2/3 portion, and lateral 1/3 here, right? This point is a McBurney's point here. So what does M stands for? M is the migratory pain. Initially, the pain occurs at the periumbilical region. This is the periumbilical region. Initially, the pain occurs at this site, and subsequently, the pain shifts from this periumbilical region to the right iliac fossa. And because the appendix is developed from the midgut, and the dermatome for midgut is the periumbilical region, that's why initially the pain occurs at this point. So subsequently, within 4 to 6 hours, what occurs is there is collection of inflammatory fluid around the appendix, and this keeps on irritating the parietal peritoneum, and which is pain sensitive. That's why that is causing pain occurring at the right iliac fossa, and more precisely this point, that is McBurney's point, which is the area of maximum tenderness, which corresponds to the base of the appendix here, right? So this is the migratory pain here. A is anorexia, N stands for nausea and vomiting, T is tenderness. If you're just pressing at the right iliac fossa, patients complain pain, which is the tenderness here. And if we suddenly withdraw our hand from right iliac fossa, that also causes pain, which is rebound tenderness here. And E stands for the elevated temperature, and this is L is the leukocytosis, and S is shift to left. Okay, since it is inflammatory condition, that's why the immature WBCs are poured from the bone marrow to the general circulation, which is causing the shift to left. Okay, and the total score comes out to be 10 here. Each and every score is just given the score of 1 except the 2, that is the tenderness and the leukocytosis here, and which are given the score of 2. And the total score comes out to be the 10, and out of the 10, if the patient is having a score of 9 to 10, that means the diagnosis is highly likely with respect to the acute appendicitis. If the score comes out to be 7 to 8, the diagnosis is likely with respect to the acute appendicitis. If the score comes out to be 1 to 4, that means diagnosis is not likely with respect to the acute appendicitis. And if the score comes out to be 5 to 6, that means the result is equivocal. It can be there, it cannot be there. That's why for the confirmation, we need to go for the radiological findings. It can be USG in the case of children, and it can be the CECT in the case of the adults here. So guys, let us magnify this area. Okay, so this is the target sign present here. This is the transverse plane of appendix. Okay, and this is the target sign here. And the diameter of appendix is more than 6 mm. Usually it is approximately 5 mm, but in this case it is more than 6 mm, and the wall thickness is more than 2 mm, right? And we can observe the periappendicular fat stranding here and the collection of periappendicular fluid also here. Okay, so let's minimize it. So guys, we have discussed the transverse section of appendix. Let us discuss the longitudinal section of appendix here. Okay, so it is just looking like the blind tube here. Okay, so it is the elongated tubular structure which is blind ended, and the probe tenderness is there. It is the probe of USG, right? If you're just pressing with this probe over the right iliac fossa, patient complains pain, right? And we can find the non-compressible structure here, and which is aperistaltic, and the mucosal hyperemia is found here, and the echogenic mesenteric fat, which is called as the fat stranding, peripendicular fat stranding, is also present here, and the dilated appendix more than 6 mm as we have discussed, and the target sign is present here as well. Okay, and the diameter is more than 6 mm, and the free fluid is being collected around appendix. And now let us discuss the CECT findings, right? So let me just magnify that. Okay, so this is the appendix here. So this is the mesoappendix here, right? And this portion, that is the appendix here. Okay, and the diameter of this is more than 6 mm, and we can find the periappendicular fat stranding and the haziness present around, and the periappendicular fluid collection is being seen here as well. So periappendicular fat stranding, periappendicular fluid collection, and we can find the appendiculate present, and which is the cause of the obstruction of appendix here. And the diameter we have discussed, that is more than 6 mm, and the wall thickness is more than 2 mm here. So guys, we have discussed the CECT findings of USG, and now we will discuss the histopathology portion here. First, we take the biopsy, we can fix it, stain it with H&E stain, and we can observe it, right? So we can find a breach in the mucosal continuity in the form of the ulcer present here. There's a breach here, right? So guys, this is the lumen, and we can find the inflammatory exudate along with the neutrophils in the lumen. Okay, and in the mucosa and submucosa, we can find the neutrophilic infiltration, and the neutrophilic infiltration is also present in the muscle layer or muscularis propria. That is the defining feature of this. Okay, so this is it with respect to the histopathological portion, and we can compare it with the histology, right? This is the histology of appendix here. Okay, so now this is it with respect to the histopathological portion. Now we will go for the management of acute appendicitis, and this is the appendectomy, and we have two types of that. Number one is the open approach, another one is the laparoscopic one, and this is more common, and this is done with the help of the antiloop, and we can use 3 trocars. So guys, what are the trocars? Trocars are medical instruments which are just working as a portal. Portal for what? Portal for the approach of scissors, the graspers, and the camera as well, and that is the trocar here. And what are the locations of the trocar? It can be infra-umbilical, it can be hypogastric, and it can be at the left iliac fossa. So in infra-umbilical, hypogastric, and left iliac fossa here. Okay, now we will go for the open approach of appendectomy here. And first thing that we do is we need to take the incision at this point, right? So let us erase that. And first thing is that we take the incision over the skin. Okay, so this is the anterior abdominal wall, and that is the chest portion here. These are the costal margins, and that is the pubic symphysis, that is the anterior superior iliac spine, that is the umbilicus here. And this is the line joining the two, that is the spinoumbilical line, and this is the point, this which is the McBurney's point, and this point is present at the junction of medial 2/3, that is medial 2/3, and lateral 1/3. So this is the first incision, which is the perpendicular to the spinoumbilical line, and which is present at the McBurney's point. This is the McBurney's point, and this is the location of first incision, which is called as the MacArthur incision, or the iron grade incision. Iron grade incision here, right? And if we just superiorly and laterally extend that, if we just extend it like that, that is called as Rutherford Morrison incision here. So this is the muscle splitting incision, and that is muscle cutting incision. What are these? We will discuss subsequently, but now we will go for the third incision present here. That is, this is a line, that is the line joining the two landmarks. First one is the midpoint of clavicle, that is the midpoint of clavicle, and this is the midpoint of inguinal ligament, right? So this is the line, and this is the 2 centimeter below to the umbilicus, and take an incision over this point. So this is the third incision, that is the lens incision here. So this is the first one, that is MacArthur or iron grid. Second one is Rutherford Morrison incision. Third one is lens one. Fourth one is the Rocky Davis, and the fifth one is the lower midline incision. Right. So guys, what is the muscle cutting incision? If it is muscle, these are muscle fibers. Okay, muscle fibers are present here. And if we are just cutting the muscle in the longitudinal fashion like that, that is the muscle cutting one. If we just cut the muscle like that, the whole muscle fibers are being injured. Okay, so we just cut it in the longitudinal fashion here. So guys, what is the muscle splitting incision? If it is muscle, right, and if you are just separating the fibers like that, so if it is the muscle, right, if you're just separating the fibers, that is muscle splitting incision. Okay, if it is the muscle and which is cutting it in the longitudinal fashion, that is the muscle cutting incision here, right? So this is what the muscle cutting and splitting. So guys, what are the layers of anterior abdominal wall that we encounter during the open appendectomy? Number one is the skin, followed by the subcutaneous fat, followed by the fascia, and followed by subsequently the external oblique muscle here. And the direction of fibers is like that. Okay, like that. As we are putting our hands in the pocket of the hoodie, it is like that, right? So it is the external oblique muscle. So next one is the internal oblique muscle, and the direction of fibers is like that. Okay, and the direction of external was like that, and internal was like that, and followed by subsequently we encounter the transversus abdominis. The direction is like transversely oriented, right? And the lower fibers are just like that, and followed by the fascia transversalis, and followed by the peritoneum as well. So guys, let us demonstrate the open approach of appendectomy. Okay, so guys, first thing is the skin layer. Then we put the incision over the skin, followed by the subcutaneous fascia, and then we encounter the muscle layer. In front, we are just having the external obliques like this. Then we cut this muscle to reach up to the internal layer, that is the internal obliques and transversus abdominis. The internal obliques is like that. Okay, and the transverse abdominis was like that. Okay, so we need to split the muscles like this, and then we will reach more deeply, and we will reach up to the fascia transversalis. Split this fascia, and then we will reach up to the peritoneum, then incise the peritoneum, and then we have entered into the abdomen, right? And we can encounter the abdominal viscera there. And how do we trace the appendix inside the abdomen? We need to trace the tinea coli. The tinea coli are just being converged. The three tinea coli are just converged at the base of appendix, which is the guide to search for appendix here. And once we have found the appendix, okay, so this is the appendix here. This is the base. This is the base, okay, and this is the body of appendix, and that is the tip of appendix. And let us consider this to be my cecum, right? So the orientation is like that. Okay, this is cecum, and this is the appendix, which is the retrocecal in position. Okay, so what do? We need to bring out the appendix. So this is the Babcock's forceps. We need to draw the appendix out of cecum. Cecum is placed inside the abdomen, but we have pulled out the appendix out of the abdomen to go for the excision of that. And once we have pulled the appendix out, we will go for the ligation of the artery of that. Okay, so the artery, the appendicular artery, is present inside the mesoappendix. We need to tie this artery and bring this mesoappendix along with artery apart from the appendix. And once the artery is being ligated, the texture of appendix is become paler. Okay, so pale looking appendix will be there after the ligation. And then what do? We will look for the base of appendix, that is the base, body and tip. We will look for the base of appendix. We need to crush the base if it is not inflamed. If it is inflamed, we will go for another procedure. But now if it is not inflamed, then we will crush. We will crush with the artery forceps. We have hold this with the Babcock's forceps and just crush with the artery forceps. The base is being crushed here. So we need to place the Vicryl suture there. So this is the base, and we need to put the Vicryl suture, put the needle ligate from this side and ligate from this side. Okay, so this is the vital suture, right? This is the base at which the vital suturing is given here. Okay, so this is done here, and then followed by we need to excise the body and the tip out, and what is left, that is the base in the form of stump that is left here, and we need to excise from the distal portion of this crushing and transfixing, that is also called as transfixation of the base of appendix here, right? And we are just leaving the stump behind. This is the stump of appendix. The size should be less than 4 mm, not centimeter, it is mm. And now if the base is inflamed, this is the appendix and the base is inflamed, what do? We don't crush it. If we just crush it, okay, and we will excise this portion of appendix and bring this like that and close the skin, then this is inflamed, that will form fistula with the anterior abdominal wall. This is attached with cecum with the inflamed margins. That's why that is able to cause the fistula with the anterior abdominal wall. That is the appendix here, and the base is inflamed. What do? We will go for the purse string suture here. So what we have given the purse string suture there, and then we have excised the body and tip apart, and this is the base which is left here in the form of stump, and this stump is inflamed. So what do? We will tighten the purse string suture. That's why this base is in the form of stump is getting buried into the cecum. So in the cecum, this stump is buried. That's why it is not exposed for the anterior abdominal wall. So the fistula formation will not be there. Why? Because this is buried into the cecum. So we need to apply the purse string suture to the base of appendix so as to prevent the risk of getting fistula formation post-operatively. Okay. So this is what the demonstration, and we will go for the steps of open appendectomy there. So guys, as we have discussed about these steps in the demonstration, and now we will go for the theory here. So first one is the skin incision, followed by the cutting of the muscle fibers of external obliques here. Okay, followed by we need to split the muscle fibers of internal obliques and transversus abdominis in the form of gridiron incision. If it is still not being traced, we will go for the further cutting. Okay, further cutting superiorly and laterally in the form of Rutherford-Morrison incision. Okay, followed by we need to divide or incise the fascia transversalis, followed by the incision given at the peritoneum. And how do we identify the appendix there? By the convergence of 3 tinea coli occurring in the base of appendix there. Followed by we need to hold the whole appendix by this Babcock's forceps. Okay, and then what is given in the next? The ligation of this artery. The artery which is being supplied is being ligated and pulled it apart, followed by the crushing of the base. This is the base. We need to crush with the artery forceps. Done. And then we have to give the vital suturing, which is given like just pass the needle and suture is like that, suture like that. This is the vital suturing, and just distal to the suture and the transfixation, just divide this body and the tip of appendix there. Okay, then we need to transfix it, followed by the cutting of the inflamed part, just distal to this vital suturing, and then we need to remove the distal portion, that was distal portion, and then close the defect here. And then what is left behind? This stump is left behind. This is the stump that is left behind attached with the cecum. Okay, so this is the appendix which in the form of stump which is left behind with the cecum. Size should be less than 4 mm, otherwise risk of getting the stump appendicitis is increased here. Okay, so now see the spatial conditions of that with respect to the appendectomy. If it is not inflamed, if we are just exploring the abdomen and we find the appendix is completely normal, then we have to explore for the distal 2 feet of the ileum so as to look for the Michel's diverticulum there. Okay, so check for that. So it can be the inflammation of base is there, the inflammation of base, then we don't crush it. If you're just crushing and excising, that is inflammatous. Okay, and this is causing the fistula formation further post-operatively. That's why we need to give the purse suture, tighten it, that is buried into the cecum. That's why the risk of getting fistula formation is nullified here. Okay, so we can go for the Z stitching or purse string suturing and do not crush the base, right? Third condition is if it is associated with the appendicular gangrene or cecal gangrene, then we go for the right hemicolectomy. And if the appendicitis is associated with the Crohn's disease, either that is controlled or not being controlled. If it is controlled case, we go for the appendectomy. If it is not controlled case, then we will go for the conservative management, not in surgery. Since in the non-controlled case, the whole gut is being so fragile as it can't go surgery. If it is going for surgery, more risk of getting gangrene, more risk of getting inflammation, more risk of getting the perforation is there. That's why the conservative management is preferred there. And the fifth special point is, and before we really go for the surgery, okay, we need to palpate the abdomen. Once we have given the spinal anesthesia to the patient, we have to we have to palpate the abdomen of patient so as to look for the lump, whether it is present or not. If it is present, if the lump is present, that means the adherence of bowel is there. Okay, so in the form of lump, what is present? The greater mentum is present, cecum is present, ileum is present, appendix is present, and sometimes the ascending colon is also present here in the form of a lump. Then we don't go for the surgery. So for the management of lump, we don't go for the surgery. We will go for the scheme, that is the OSCHNER-SHERREN regime for the management of appendicular lump. So guys, we will go for the conservative management of the patient, as we can give the IV fluids, IV antibiotics and the painkillers to the patient, and nil per oral for 48 hours at least, right? And we have to check for the vitals of the patient, the BP, respiratory rate, temperatures 4-hourly, as the size of the lump is increased or not, and the tenderness is being increased or not. Okay, so we have two cases: whether the patient recovers as its pain is decreased, size is decreased, the fever is lesser, that is decreased here. And the second condition, if it is not, does not recover, as the condition of the patient worsens as time passes by, as the pain increases, size of what? Size of lump, and fever also increases. That means patient does not recover, and patient recovers when the size is lesser, pain is lesser, fever is just being reduced, right? So if it is not improving, so that might suggest us that there is formation of appendicular abscess there. So what do? We will go for the extra peritoneal drainage of abscess. So we need to drain the abscess, and then we will again follow the scheme and wait for few days. The second condition is, if the condition of the patient recovers, then what do? We will discharge on third and fourth day, followed by we call the patient again after 6 weeks to go for the interval appendectomy. So we can go for the laparoscopic procedure, or we can go for the open procedure. In the open procedure, we need to provide the lens incision to the patient, which is cosmetically better incision here. So we will go for the complications of appendectomy, the complication of surgery. Number one is excessive bleeding, that is the first complication, followed by the injury to right iliohypogastric nerve there. The more risk of getting inguinal hernia, especially the right point. We just operating at the right side, more risk of getting right nerve damage leading to the right inguinal hernia there. So next one is the wound infection. That is the most common complication after the appendectomy there. So next complication is the fecal fistula formation. Okay, if it is inflamed base, then we transfix it, remove this portion of appendix, and close the defect, close the skin surface. And what occurs subsequently is there is the fistula formation with this inflamed stump with the anterior abdominal wall. That's why we should not go for the crushing of base. So what do we go for? We go for the persistent suture, tighten it, and after tightening, what occurs? That stump is being buried into the cecum, and the risk of getting fistula formation is nullified here. Followed by the portal pyremia. Okay, this inflammatory fluid, the inflammatory content is being poured to the portal vein as a drainage, that is called as portal pyremia there. And followed by next complication is the intestinal obstruction, that is the inflamed base, and we have closed the defect. That inflamed base can join with the bowel, leading to the bowel obstruction. That's why it is one of the complications of that. So next complication is the stump appendicitis. If the size is more than 4 mm, the stump which is left behind, the size of is more than 4 mm, basically 5 to 6 mm, more risk of getting the appendicitis. The stump appendicitis is there. So this is it with respect to the second part of acute appendicitis. So thank you for watching. So guys, if you're just having any doubt or inquiry, you can go for the comment section below. Hit the like button for the sake of the motivation, and don't forget to subscribe. Pressing bell icon will give me some vibe. So till then, keep integrating. Thank you.